Take two.
Welcome to the While You Grow podcast with Dr. Courtney Addison and me, Addison Powell, where we will dive into all things pediatrics, occupational therapy, and other important topics around children and development. So, if you are a parent, occupational therapist, student, or just want to learn more about occupational therapy and pediatrics in general, then keep listening. For more information on the podcast and to follow us on social media, take a look in the show notes. Let's get started. Welcome to the While You Grow podcast. I'm Addison Powell.
I'm Dr. Courtney Addison, and I have two new guests with us today.
Yeah.
I'd love to introduce Karina and Britney. They are students here at the PC OTD program, and today we're going to talk about the pediatric fieldwork experience. So this episode is for any student out there, any person that is interested in going to OT school, site supervisors, CIs, all those things. We're going to talk everything pediatric fieldwork experience because it's quite unique, wouldn't you guys say?
Oh, yes.
Yes. So all three have had a pediatric fieldwork experience. All are interested in pediatrics in some sort of fashion. So I thought it would really be awesome to get their perspective on kind of how their fieldwork experience went. What were some of the barriers, challenges, all those different things. So all three different. So if you guys want to kind of talk about where you guys were and kind of what the population was when you went on your pediatric fieldwork experience. Karina, do you want to start?
So my fieldwork rotation was in Columbia with Prisma Health, and it was outpatient pediatrics. So most of the children that I saw during my rotation was between, I wouldn't say like 3 to 10. That was kind of the range. But occasionally we had some babies and a few like older children. And we saw a lot of diagnoses. Most of them were diagnosed with, autism.
Mm-hmm.
And then just a couple that were kind of not commonly seen. So a lot of research is required when you work with peds prior to like treating children, just to get to know like what that diagnosis is and what like impairments would you see with that or commonly see.
Did you ever do research before? I found this way back in the day when I did mine, that you knew what diagnosis was coming in, but they didn't quite exactly match what was on the research.
100%. I feel like all the time you read like, oh, this is what the common signs are. And then you meet the kid and it's like, whoa. Let me change my plan.
Exactly. Addison?
Yeah, so I did outpatient pediatrics down in Charleston. I loved it. My youngest kid was about 18 months. And then my oldest was 19, so I got a pretty good range. Autism was the most prevalent diagnosis, ADHD as well. A lot of them, if they had autism, they also had the diagnosis of ADHD. But I also had some really unique ones. Can't remember the names of them because they're kind of rare. But it was nice seeing all the different range because we got to work on so many different things, and I got to educate myself more about some of those other diagnoses out there in pediatrics.
Very good. Britney?
So mine is very similar to both Karina and Addison's as well. It was in Greenville with Prisma, outpatient as well. Kind of with Addison, my youngest was 9 months and my oldest was 18. So a very wide range of ages. But yeah, very autism, ADHD, same kind of boat that they were in.
Very good. So we kind of talked a little bit before we started airing and kind of describe what you wish you would have had more experience with before going on an intensive pediatric rotation.
Yeah, so I wish I would have had more experience with babies. I didn't really get to see a lot of babies during my rotation, but just getting to know that experience, especially because I have a baby.
Karina has the most angel baby. And do you want to tell them about your, like when you had Aaron and how that impacted?
Yes. So I had Aaron in between my two level 2 fieldwork rotations.
Do you recommend that?
No. I love Aaron,
But if anybody could do it in our class, it was you.
Yeah, definitely.
Honestly.
it's tough. But just getting to know how to work with babies, and then also experience with children with CP. I did not really get to see. We did have some children with CP, like some type of CP, but it wasn't to the point where it was really impacting their ability to participate in occupations. But just being able to have that experience, just in case, like in the future, if I go into peds, I want to know how to treat a kid with that. Yeah.
That diagnosis, yep.
Honestly, I agree with everything she just said, because I also didn't. I saw maybe 1 or 2 kids with CP, but they were actually seen by other therapists, whether that be an occupational therapist or a physical therapist. And that's what I did like by rotation. If we had a kid that no-showed, or just we had a little break with my CI, I would go with other professionals, whether OT, speech, PT, and I got to see the kids they worked with. But CP is one I definitely wish I would have gotten to see more, as well as kids that have had a stroke. There was a couple kids, I think, in the clinic. Again, they weren't our kids that had strokes, but I thought it was like really interesting to see, because most time when you think of stroke, you think of adults. And so to see that in a child and how that impacts their ability to play and work in school and all those other things, it was really interesting. And then also with babies, like I said, my youngest was 18 months. So I do wish I would have had a little more experience with babies going in, which is why I loved the baby day that we did for this
Right.
class. Like that's something I really wish we would have been able to do.
There were so many babies here.
Yeah. It was a lot of fun.
Amazing.
It was a good day.
But that's great feedback in that, getting to handle babies and being comfortable with them. And it's much different. And Britney, you said this earlier too, than dealing with a toddler, dealing with an older kid, that are a little bit more durable, I guess, at the time.
Yeah.
But just anytime you get a chance to interact with a baby, whether it be a family member or a community member, take that opportunity just so you get comfortable in kind of what they do and what to expect. And then to add on top of that, if they have a diagnosis or have an impairment, how to protect that baby from getting injured or making a safe environment for them. Yep.
For sure. I'm going to say with mine, what I wish that I kind of was better at before I started was treatment planning and documentation. Because like in class we learn the SOAP note, which I feel like is like the skeleton of all documentation. But kind of what Addison was saying is when we go to Fieldwork is kind of get the flow of what your CI and how they write, kind of ask them for any like hints or improvements you can make with your writing. But with documentation on a level 2, it's like insurance will be reading your notes.
Right.
So you have to show how the child presented, what you did, and their progression throughout their treatments, because in peds with outpatient, I had the same kiddos every week at the same time. So just making sure that the progression is being seen, or if it's not there, to state that in your notes for insurance purposes, because we're there for 12 weeks.
12.
So just remember that the kids still need to get approved for therapy after you leave. So making sure that your progress notes are being well written and meeting the marks.
Yep.
Yeah.
That kind of transitions to a good point. I think documentation at the pediatric level is the hardest because you are justifying services to people who never see the kids, and never interact. And even from a standpoint of a school or an IEP, same thing. Sometimes you're an outside perspective. You're not interacting with that kid all the time. So documentation is so key in pediatrics. What are some tips, Brittany, you've already shared, kind of learned from your CI, but what are some tips that you guys have after going through a pediatrics rotation on managing that large amount of writing and large amount of documentation?
Okay. So, I think if you go into a pediatric rotation, any rotation really, there's going to be challenges. There's really good sides to peds. I really enjoy my time. But as far as documentation go, just because I think we're students, we really want to make sure our documentation's really well written. That takes extra time. But just planning out it's time for yourself to really just take a break, step away, because it's needed. Just, I think, looking at my CI and how she wrote her notes, I mean, she has a lot of experience.
Right.
And just the way she's able to type those out and be done by, like, before she leaves, I'm like, wow. I want to be like that. That did not work for me. But it's just a learning experience and
right.
just accepting, like, oh, I'm a student. I cannot write like my CI because I don't have years of experience.
Right.
In peds. But just making sure you carve out time for yourself during the rotation. Make sure you take some time off and stepping away from your computer, especially after work. One of the things I did was just hang out with my baby. And even if I had to like document later into the night, at least I knew I had time and felt better when I went back. Because it gets to a point where you're like, I don't know what to write anymore.
Yes.
But that's a tip that I recommend. Yeah,
I feel like I have a lot to say on this because I struggled at first with documentation because I was like, I'm taking too long. Mm-hmm. And then at first she was giving me more feedback of like how to make it better, which I needed. That was something that I will say everybody needs to do is daily, weekly, whatever, you need to be asking your CI, how can I improve? Whether that be documentation, whether that be treatment, how you interact with the parent, how you interact with the kid, all of that. Like always accept that feedback because they've been in the workforce. They know what they're doing. Mm-hmm. But in terms of documentation, I kind of picked up on my CI's way of writing notes, which helped because it kind of gave you an outline of what you needed to write in your notes. And still, I was slow at first, and then you start getting the hang of it and you get faster. I do know for a lot of people in our class, I think what either made or break their pediatric rotation was documentation and the amount of time mm-hmm. outside of the clinic mm-hmm. that they had to do documentation. For me, I did have to do pretty much all of mine outside. Same, yeah. Because with kids, you can't really document while
point of service contact, yeah.
The only kid I think I ever did that with was my 19-year-old.
Right.
Mm-hmm. And we're talking about a 19-year-old who, it was mostly just like physical
impairments.
Impairments that he had. So like I could say, hey, do this, and then he'll do it. Obviously, I'm still paying attention, and like if I got to see like him start to go a little lazy, I'm like, all right, let's shape it up. You got it. But I was able to document with him. However, all my other kids, not possible because you're watching to make sure they don't cut their hair with scissors and they're not writing on the walls and running out the room. But then getting to, I'm blanking. I guess knowing that you are going to have to spend time probably outside of your actual hours in the clinic, you are going to be doing documentation. And for me, that wasn't so much a big deal because right. I love pediatrics. It's what I want to do. So I knew going in that's what was going to be expected of me.
Right.
And you do get faster. Like by the end, I think some of the notes I could get done in 5 minutes.
Right, which is the typical time you have.
Yeah.
You know, if you think about things. Britney, we've also talked about this, and like and the others to weigh in. I find that the pediatric rotation is also tough because it's very emotional. When you work with kids you're not only working with kids, you're working with their families, but you're working with, sometimes they're in really kind of tough situations or they're having a hard time. It can be very emotionally draining because you guys all have big hearts. And, when a kiddo comes in and they're struggling, it tends to weigh. What is some advice you have for dealing with some of those emotional sides of a pediatric rotation?
Well, I feel like as OTs, we're all empaths. So it just kind of comes with the role of being an OT.
Right.
But I feel like highlighting where they're improving, like stating like this is where we started and through these treatments, this is where we're at now. Like look at the growth.
Right.
So I think always parents might get in a rut of being like, well, how are they doing? Are they doing any better? I feel like they're still stuck at this same spot. And then you just have to go back to, yes, we're still there, but this is where we started. So we're progressing up and improving and getting better and just seeing that growth and recognizing that growth.
That's very good. Ladies, do y'all have any other advice? Did y'all have any emotional cases?
Not not for me, not super emotional. I did get to see a little bit, I guess, it's not really emotional. However, I did get to see a difference because the place I was at, they actually had 2 locations. They had one in Mount Pleasant and they had one in Goose Creek. And those are very different areas. Mount Pleasant, if anybody knows anything about Charleston and Mount Pleasant, like that is, it's very expensive to live there. There's another community right nearby that's like its own city. And it's very well known that those families that live in that area are very, very wealthy. So then you got to see, however, Goose Creek, while Goose Creek is a really up and developing area, it's also surrounded by Somerville and Moncks Corner, which are lower SES compared to Mount Pleasant. So I got to see the difference in the families and the support they had for the ones that were in Mount Pleasant and then the ones in that Goose Creek, Moncks Corner area, which I thought was very interesting.
And then I guess, we don't want to make this a super long one. We just want the short and sweet facts. But talk about, assessment. So as an OT, that's really what defines us a little bit more than a CODA, although we love our CODAs in pediatrics. Most of the time they have way more knowledge than we do. But talk about having to assess a child, talk to a parent, get all that done, and maybe some strategies for students that are listening.
Be familiar with your assessment before you go in.
Okay.
I know it's hard to study assessments, considering that each facility kind of has their own assessment tools that they use. But one good thing is to email your CI and ask, okay, what assessments do you typically use, so that way you're familiar with them before you go in.
Right.
But it's still a learning process, because you may have one child that's able to sit through the assessment, and then the other child is like, you can't even do one thing because there's just so many factors to consider. But be familiar with assessments. Know what you're going to screen for. That's a big thing, because a screener can kind of determine, I wanted to do this, but now that I screened for this, quickly, let me change the assessment, so that way we get more valuable information.
Very good. Yeah.
Yeah, so we kind of talked about this off camera before. I did a number of assessments. However, none of the ones I did, parents were in the session for the assessment or the evaluation. So I didn't have to try to do both, because it definitely would have been hard. However, I do wish I would have had the opportunity to try to figure that out. But even just trying to do an assessment with some of the kids, it was just the kid was hard. We had this one kid who didn't know a lot about him coming in, just that he had a diagnosis of autism. He was previously at another clinic, and we still had to do our own evaluation. And so we brought out the bot, because that's the age range for him. And then he got there, and immediately we're like, we're not going to be able to do this at all.
Right.
We even started doing some of the things from the Peabody, and even that, it was just it wasn't possible. Big eloper. For those who don't know what eloping means, they run away. They want to do their own thing. You can't keep them in a room.
Right.
And so we had to adapt with that. We didn't get through an actual assessment, which you put in your notes, unable to perform this assessment. Standardized, non-standardized, just, it wasn't possible. But then you can do other things in the clinic to get a good idea of what this kid is, what are their strengths, what are their weaknesses. And then we also got to, afterward, we interviewed the parent and asked for all this other information. But yeah.
So mine was a little bit different than Addison's. All of my evals were on Fridays, and all of them had parents that came back with us. And one thing that I learned throughout my rotation was being able to transition better from the parent interview to the assessment, because we always started with explaining what OT is and what the test is assessing, and then just getting a parent-client interview. And being able to, parents can go on tangents, I guess is the best way to put it, and getting them to kind of reel it back in so you can do the assessment with the kid was hard for me at first, because I didn't want to be this is coming off rude, or maybe I can get more information if I let them talk, but then you only have an hour.
Right.
So if you let the parent continue to do the interview, you have less time to do your assessment, which is where you get your data, and if they need services or not. So learning to kind of come up with a quick, not slogan, but a quick sentence that you just go back to kind of reel it in to say, hey, now I need to start the assessment on the kiddo. If you have any more questions at the end, I'll be happy to answer them.
Oh, that's a good strategy.
Yeah, I think that could go for documentation as well. Like having yourself your own outline. It's like even though every kid is different and what you're doing with that kid is different, you can still almost build a skeleton of like your documentation, and then you just fill it in. That'll also help you do your notes so much faster.
Yes.
Right.
And speaking also, I thought about this later about the documentation. What I found challenging, really challenging, in my pediatric rotation was actually writing progress notes for kids when I was only a month in. Because you're supposed to, they're done typically every 3 months.
Right.
And you're supposed to show the progress from the previous one to this one, and you've only been with the kid for 4 weeks.
Right.
And you see them once a week, and most of the time kids sometimes don't, or parents sometimes they don't show up.
Right.
So then there was one I was having to write a progress note for, and I seen him one time.
Right.
It's like, it's hard. You had to go back and see, okay, where were they at before? What did I see from this one time I saw them? That was really, really challenging, but that's where you can go back to your CI and be like, hey, you know, what have you seen? Just because I haven't had a lot of time with him.
Right.
That way everything is in the documentation that needs to be in there.
Right.
And you can read previous sessions that your CI had with the kiddo before you started. And I think that was very helpful with me with progress notes.
But that was definitely one of the challenging parts because you're like, I've only been seeing this kid a couple of times and I'm supposed to talk about 3 months of progression.
Right.
But I highly recommend the cheat sheet with the evals because with me, I kind of get nervous, as y'all know, when I'm talking to other people. So my mind tends to kind of go blank sometimes. So having that cheat sheet with like how independent they are with all the ADLs listed out and being like, mom still helps with upper body or lower body, or they lift their hips with pulling the, like being able to write down little reminders for when you do go back and write the assessment was very helpful for me because if you try to like remember all of that, you're gonna like something's not gonna be written down. And with us, I personally didn't like bringing in the computer because I felt like it wasn't like one-on-one with the patient and their parent. So I just had my sheet and a notebook and the assessment form, of course, because I just feel like that's more personable to have like paper and eye contact rather than, okay, so this, and then typing it.
Right.
So all of my documentation was done after my day. So just having the cheat sheet, I think, was very, very beneficial.
That's good. That's good feedback.
I think talking a little bit like treatments, like how treatments went for y'all would be a good idea, just like really quickly.
So,
you want to go?
With my CI, like you said, they have a ton of experience, so they can think on the fly.
Right.
Well, as a new student kiddo in peds, it does not work. So I made what my CI recommended is, like I said, I had the same kiddos at the same time every week. So I had a computer given to me by Prisma. So I had my own computer.
Oh, that's nice. You're not going to get that everywhere.
Yeah. So I could, I was able to do my documentation at home, which was great. But I made a little client sheet. So I the name of the client and kind of like their goals and how they're doing now and what they progressed from, just to have like a cheat sheet. So at Monday at 8 a.m. I could be like, okay, this is my 8, 9, and 10, and kind of have like a brief chart review. But that also helped with treatment planning because I had my goals in front of me. And so I highly, highly recommend making maybe 6 treatment activities that you could do.
Right.
Because one, with me, I had my notebook in my treatment sessions as well to take notes because I was doing my documentation after work. So I could write down how much I helped the kiddo or how they did and yada yada. But having 6, I definitely highly recommend because you never know how the kid's going to present to you. And if they're interested in said activity. And so I would make my 6, and then if they didn't like it, I would just cross it out.
Yes.
And then I would check the ones that I actually did, so when I went back in my subjective, I could state, this is what we did, and this is how we did.
That's such good advice.
So definitely having everything where I could, like, write little notes of how they did. And this is, like, by the activity. So I wasn't, like, trying to rush, because like y'all said, you do not have much time during
No.
treatments to take notes. So it was kind of, you were taking these notes in between the 5 minutes you had of them putting their socks and shoes back on, taking them to the parent, and grabbing your next
Right.
kiddo.
Yeah.
Right.
Just making it easier on yourself with time management and being able to quickly write down little notes here and there.
Yeah,
Yeah.
that's definitely really good. I did the same thing. I had like a list of like all of my patients and their goals. And then I started out by planning like you did, having different plans for treatment sessions. And that worked for me for a little bit, but then I realized when it didn't go that way, I struggled to adapt and grade up and grade down. So and that was something I talked to my CI. I was like, what is your, like, I need help with this. How can I get better at this? And she's like,
that's one of the
planning.
that's one of the biggest things that we get feedback from CIs is the student's great, struggles with grading up and grading down. And it is such a natural thing, and as you become a more, seasoned OT, it just comes naturally. Like, oh, we're going to do this next. But even when I think back to telling students how to grade up, it's hard because it's natural, So, but continue. Sorry.
But so because of that, I stopped planning. I literally would just look at what patient I had next. We looked at their goals. I went and got them, and we were thinking on the fly because that's what I needed to do to get better at that.
Right.
To also just trying to come up with something on the spot because you can plan 6 and they're like, no, I'm not doing that.
I'm not doing any of those things.
I'm not doing any of those, which is so common. So I forced myself I trained myself to think on the fly, to grade it up, grade it down. And then sometimes too, you do like a joint treatment session with like another kid.
Right.
So like trying to, like, this one kid wants to play with your kid, and they want to play this, and you find a way to make that activity helpful and work for your kid.
Right.
And so not planning helped me.
Right.
However, some people do need to plan.
And going along with that, I think the longer you're there and the more you get to know the kids,
Right.
the more
Yes.
your planning and activities become more client-centered.
Right.
Like, maybe your kiddo likes baseball, so all of your activities
Right.
correlate with baseball to keep them intrigued. Because one week, they might have loved this activity, and then the next week, they're like, I'm not doing that. So just being able to have something to pull out of your sleeve of like, okay, this is an interest, maybe I can print off a sheet that deals with this activity they like in case it doesn't go how
Right.
they planned it. You
Right.
can always have a backup of an interest that they like.
Right.
Holidays.
Oh, yes, holidays.
Always check with your families, though, to make sure they do celebrate certain holidays.
Yes, that is a
But,
big thing. I did run into that a lot
Yeah.
of certain holidays.
However, when they do, holidays are the best.
I had Thanksgiving, Halloween, and Christmas.
Oh, you had the big holidays. Yeah, I
Yeah.
had like 4th of July. I think I had Father's Day. Maybe a couple others. I don't know. Not the big holidays, though.
No, mine were, yeah.
But holidays also were a good opportunity because you could do one activity
For the whole
and do
kid.
it for every single kid, but then you figured out how to grade it up and grade it down.
Right. Right. And and it changes, and that's the unique thing of, being an OT is that creative process. But kiddos, they're very smart and they know you're a student. So talk about like establishing rapport with your kids. Cause I find in different rotations, like that's the biggest thing. If I give any advice to any student that's going out there or anybody that's transitioning to pediatrics, learn how to build rapport. Because once you have that, you can kind of work with the child on anything, even if it's difficult tasks, they trust you. That's huge. You guys want to speak to that?
Yeah. Do you want to start, Karina?
Yeah, so really it just depends on the child, but with some you can build rapport just by talking, depending on their age. Others, you really just have to
Get in there.
get in there, get to know them, and just learn like what things they like, what things they don't like. But yeah, it just really varies. It's not like with adults. I did orthopedics before this, and building rapport with adults is so different with kids. But in a way, I like building rapport better with kids than with an adult.
Because it's like play. Like, I think
It
the
is.
best way that I built my rapport with my kiddos was like getting into their imaginary scenarios that they made up and like
Oh, yes.
playing with them and just like being involved with their creation of a certain activity, like just like letting them lead in a sense,
Right.
Following, and I think that really just like builds the trust with the kiddos. It might take a little while, like a few weeks. Like, don't feel bad if it's like week 3 and they're still like, who are you, like that type of thing.
Yeah.
Just continue to just try to implement yourself and put yourself in their shoes and in their world, because that's really what it is. It's like, we're there, but they're in their own world. So just try to get in there with what they're doing.
Yeah, I would definitely say that first day that it was just me with the kid, like my CI wasn't super involved and it was my time to shine. I liked letting them that first day pick what they wanted to do, and then somehow I had to make it therapeutic.
Right.
And it was still therapist guided, but the kid got to pick what they wanted to do.
Right. Right. And that goes a long way, you know, just being playful and matching their energy, and also knowing when not to be too big, but when not to be too small. You know, you don't want to over arouse, but you also, you know, it's just finding out that kid. So, yep. Yeah. Well, I really appreciate it. This was really good. Yeah. And I know this was like last minute idea of Dr. Addison's side quests. That's a separate podcast, but this is, I hope students listen to this and listen to your advice and just know, like, one, don't take anything personal your CI says. No. They really are there for your guidance. Enjoy it, but know it's going to be hard work.
Yeah.
Right?
Yes.
Right?
It's not easy, but it's very rewarding. And I enjoyed everything about mine. I had a great CI.
Yeah. Didn't your CI name their child after you?
She did. Maybe not after me.
Oh, okay.
However, she did. She had Addison on her list.
Yes.
And they're like, it was so weird. Like, we had this on our list before I even knew you were going to be my student. And then I thought it was crazy that when I got you and saw your name, and on my last day, she was like, I don't think I told you. We decided to name our little girl Addison. I was like, I was so happy. It just made it so much sweeter, even though it technically wasn't after me, because I told her, I was like, I'll try not to ruin the name for you. So that was a little bit of pressure, but yes.
Excellent.
I think it's great to see the progress in your kiddos. Like,
yes.
We are only there for 12 weeks, but that's a lot of time to see a lot of progress.
Right.
A lot of time for you to kind of get attached to your kiddos that you see.
Yes.
Like, I know, like, the week after I finished my rotation, I was like, well, I would be with this kid right now. I would, like, look at the clock and be like, I would have been in a treatment with him or her. And it's just kind of, you get into a rhythm.
Right.
And once you get in that rhythm, I think everything kind of falls into place.
Yes, it does.
Right.
I was very sad leaving my rotation.
Oh.
I was very sad.
Oh, well, thank you guys for your advice for students out there. And again, this is our 10th episode, right, Addison?
Yes, number
our
10th
episode. So please download our Spotify, YouTube, all those things that I have no idea about.
So yes, we have our Instagram.
Yes.
YouTube. Listen, subscribe, like, comment, please. Spotify, make sure you hit the download button. That's what we need right there. Again, like, subscribe, comment. We want all of it. We want your feedback. We've gotten a few little fan mail.
Yay, we love fan mail.
Yes.
And we would love questions. Or like, could you do an episode on this? Because we want to know, right?
Yeah. We want all the feedback.
Yes.
I've enjoyed doing this. I can't believe we're already on episode 10.
It's wild.
That's crazy. Yeah.
It's crazy.
And like so many topics over those 10.
Yeah, lots of topics.
And we have so many more planned. I think next week we have like 3 or 4 scheduled to record.
Right.
So
exciting.
Listen in.
Exciting.
All right. Well, you guys will be graduated probably next time you guys come on the interwebs. So, it's going to be so exciting. But thank you guys for listening.
Yes.
Have a great day.
Bye.
Thanks for listening to the While You Go podcast. If you learned something on this episode, please like, share, and comment. Join us next time as we dive into all things pediatrics, occupational therapy, and other important topics around children and development.